Good morning, students. Today we'll be learning about the gluteal region. And my objectives are, first we'll be looking at the muscles who are present in the gluteal region. We'll look at their proximal distal attachments, their actions and their nerve supplies. And then we'll be discussing about their arterial supplies, nerve supplies and the venous drainage accordingly, and their clinical application. Especially we'll be talking about the placement of intramuscular injection, deep intramuscular injection. Now, first let's review the hip bone. We have already discussed this hip bone in detail during the lecture of hip joint. Only just quick recap. So we are looking at on the outer surface of the hip bone. If you can just examine a hip bone, preferably a real one, not a plastic one, you can see this raised area. This is anterior gluteal line, and there you can see the posterior gluteal line and the inferior gluteal line. So these lines, if you see them, it's fine. Otherwise, this will serve. And these lines are useful for placement of my muscle attachments, specifically the proximal muscle attachments of the gluteal region. And then we can see this very obvious dip. That is my greater sciatic notch, a very common place dedicated for immersion or entering of so many important structures within my pelvic cavity. They are either entering or leaving, and then a tiny one, the lesser sciatic notch and the acetabulum. That's the place where head of the femur goes and makes a very strong synovial ball and socket type of joint, spheroidal, and that's my hip joint. We have already talked about that. Now we are looking at the back, and this is the gluteus maximus. This is the real picture of a gluteus maximus after removal of the fat skin superficial fascia. So this is the whole bulk of the gluteus maximus, one of the bulkiest muscle of human body. And then this is my gluteus maximus. The name says is the big one, maximus. And then this is, you can see a drawing of the same gluteus maximus. You can see its attachment, the proximal and distal, and then later it continues, it ends its journey into this band, and that is my iliotibial tract. We talk about this band where in the lecture of anterior compartment of the thigh. And now the proximal attachment, guys, this gluteus maximus is one of the very important muscle, and you should be doing in maximum detail about this gluteus maximus. So it's coming from my ilium, where posterior to the posterior gluteal line. You have seen it right now. And then the dorsal surface of the sacrum and coccyx and the sacrotuberous ligament. And then the distal attachments, the 3/4 of my gluteus maximus, it goes and it becomes iliotibial tract. Only the 1/4 of this muscle is attached to a bony location, and that is on my proximal femur, and that is famous with the name of gluteal tuberosity. So that 1/4 of the fibers, they are distally attached or insert in that location. But the 3/4, a big majority of this muscle, is going and contributing this very strong band, which is known as the iliotibial tract, and one of the stabilizing factor for my knee joint. And this muscle is innervated by inferior gluteal nerve, and this inferior gluteal nerve is a branch from my sacral plexus. And then the actions worth knowing, worth remembering, let me read it for you. So if we see, if this muscle is acting from the pelvis, so it can extend the flexed thigh and bring it into the line with the trunk. And if it acts from distal attachment, that was from the proximal. So if it acts from the distal attachment, it may prevent the forward movement of the trunk from producing flexion of the supporting hip during bipedal gait. Guys, these are the different gaits. We'll be talking about them. The muscle is inactive. When we are standing, it's not that active. Remember, when we are climbing, when we are going upstairs, this muscle becomes very tight. When we are in a walking, swaying forward at ankle joint, so it's helpful at there. And when we are bending forward at the hip joint to touch the toes. It acts with the hamstring when in raising the trunk after stooping by rotating the pelvic backwards on the head of the femur. It is a tensor of fascial latae, and through the iliotibial tract, it stabilizes the femur on the tibia when the extensor muscles of the knee are relaxed. So this is a big muscle. It does a big job Never forget a very powerful extensor of my hip joint. And when we are going on stairs, when we are climbing stairs, this is a very instrumental muscle. When I'm rising from a chair, I'm holding my hands on the arms and I'm lifting my body. This is the place where gluteus maximus plays a significant role. When you're rising from the chair, and if you're not, you may be supporting your hands, but rising from a sitting position to a standing position, gluteus maximus is very instrumental. And this is a very common location for giving deep intramuscular injection. Remember, we always think deep intramuscular injection can only be given in gluteus maximus. Remember the fact. Sometime your patient is bedridden and now you have no way to reach to the gluteus maximus. Somebody has fractured the femur or this and that, so you cannot move him a lot. So we can use lateral aspect, that is through the vastus lateralis. That is also a big deep muscle. The idea is we should go deep in. It's not only the gluteus maximus or the deltoid are the only two sites in human body which can be used for deep intramuscular location. This point needs to be very clear, and it has a high clinical relevance, and it is a very common useful tip when we are handling the patients in a real life situation. Now, the safest location where we can inject the intramuscular injection, if we have decided to inject, you can see that this site is showing you, this cross is showing you the safe area and the very nice tip. You can put your hand and between your middle and the index finger, so you can figure out yourself. That's the safest location because we are preventing a lot sciatic nerve and its branches. So that's the safest location if you are planning to give a deep intramuscular injection. Now we have removed the gluteus maximus. Now we are looking at someone who's underneath my gluteus maximus, and this is my gluteus medius muscle. And now this gluteus medius muscle, proximally it's coming from the external surface of the ilium between two lines, anterior and posterior gluteal lines. And then distally it's coming where? To the lateral surface of the greater trochanter of the femur. You can see that. Lateral surface, outer surface of my greater trochanter of the femur. And then it's innervated by superior gluteal nerve. My gluteus maximus was innervated by my inferior gluteal nerve. Superior gluteal nerve is also coming from my sacral plexus. Then this muscle, primarily this is an abductor along with my gluteus minimus muscle. It stabilizes the pelvis on a stance phase. Tendelberg sign, which we have learned previously, one of the very important muscle. If an injury has occurred to the superior gluteal nerve because of any incidents, so then it will be really instrumental thing which stabilizes the human pelvis and preventing it from tilting. There is a separate presentation available for Tendelberg sign. A video is available. So it's highly recommended. It's a must watch type of activity. I hope we are clear. Now we are looking at, we have removed the gluteus medius, we have removed the gluteus maximus, now we are at gluteus minimus. The name says is a tiny one. And this gluteus minimus, it's coming from the external surface of the ilium between the anterior and inferior gluteal lines. You remember we talked about those lines. And then it also going where? To the anterior surface of the greater trochanter. That was going to the lateral surface. And then it's innervated by the same nerve, superior gluteal nerve. And then it is also an abductor, and it is the same, it is an assistant to my medius, and it has a significant role in maintaining the trunk during the stance phase when we are walking, swing right, so prevents tilting. Then we are looking at a very important muscle, and this muscle is coming out of my this greater sciatic foramina. Now it's not notch because this ligament, what is this ligament? From tuberosity to the sacrum, sacrotuberous ligament. And this is from the spine to the sacrum, sacrospinous ligament, this tiny one, and this big one is my sacrotuberous ligament. And look at this muscle is coming out of the pelvic cavity and coming and getting attached on the proximal femur. This muscle is a very important muscle, and this is piriformis. This piriformis helps us in identifying various structures. Proximally, it's coming from the anterior surface of the sacrum, which is not visible on this. If you look from the front, within the pelvis, you can see the anterior surface of the sacrum. From the sacrotuberous ligament, this is my sacrotuberous ligament. You can see it's coming close by. So these are its proximal attachments, and distally, it's going to the greater trochanter of the femur, the superior border of that, and then it is innervated by anterior rami. They are coming from my first sacral and second sacral spinal nerves, S1 and S2, and this muscle is one of the lateral rotator of my extended femur at the hip, and it helps in abduction of the flex femur. But this is one of the lateral rotator. We have many. Then there is a series of muscles which has been shown in this image. Let's label them all. This number 1 is my superior gemellus, who supplies nerve to obturator internus. Obturator internus muscle, you can see that, this number 2. And this is my inferior gemellus. And there we can see another muscle which is quadrangular. We call it, it's in the femoral region, quadratus femoris muscle. So all these muscles, look at it, superior gemellus and obturator internus. Nerve to obturator internus, nerve to obturator internus. Inferior gemellus, quadratus femoris, and their nerve supply, nerve to quadratus femoris, nerve to quadratus femoris. This is a typo. This should be read as quadratus femoris, not quadratus internus. So this is the action of my superior gemellus, weak lateral rotator of femur at the hip, and this is the lateral rotator, lateral rotator, lateral rotator. So all of them are lateral rotators. I hope we are clear. Now let's look at the structures under cover of my gluteus maximus. Gluteus maximus has been cut, so you can see underneath, we can see the sciatic nerve, one of the big nerve of human body, and you can see the neurovascular bundle who are emerging above to my piriformis. So they are my superior gluteal nerve and vessels, and those who are coming below to the piriformis, they are named as inferior gluteal nerve and vessels. And this is the basis on which we can identify them. And there you can see a nerve going down. This is posterior cutaneous nerve of the thigh. And there you can see things has been cleared. We have removed the medius, and now you can see the minimus, and you can see the distribution of my superior gluteal artery through its different branches and vice versa. Now this is the table. We talk about those nerves who are located in my posterior gluteal region, and also they are innervating the structures who are located in my posterior thigh. And then these are the muscles. We have talked about them. I have shown you all of them. And this last but not the least, the arteries which are found in the gluteal region and the posterior thigh, and they are responsible. All these tables, they have been taken from Moore's anatomy. Thank you very much.